Next talk is by Dr. MARIAN on phacoemulsification in presence of orbital and ocular adnexial problems. Over to you, MARIAN.
Yeah, good morning, everyone. Thank you, Dr. Sandeep, for putting up such a nice IC. So in this presentation, I acknowledge all my cataract surgery colleagues. So let us see what we can do. So this is a huge topic. I will just put up a few points in each area. So coming to lacrimal drainage anomalies. So total NLDO, no doubt, you have to do DCR or DCT. After DCT, wait for two weeks. DCR without intubation, wait for 3 weeks and then do IOL. DCR with intubation, wait for 6 weeks. This is for the stabilization of the bacterial flora of the conjunctival fornix. Partial NLDO, if the patient is symptomatic, do a syringing and you can actually proceed with IOL. What we have seen is they might become total NLDO after cataract surgery. Canalicular blocks, Roplas is negative, but syringing shows common canalicular block. So here decision is based on your conjunctival swab. If the swab is negative, you can go ahead with IOL surgery. If the swab is positive, you have to treat and then go ahead. But before putting it as common canalicular block, do a probing and confirm, because sometimes atrophic sac, that is very small sac, mimics like canalicular blocks. So this is one of our patient, adenocystic carcinoma maxilla, status post maxillary reconstruction, radiation, had NLDO, ectropion, lag of thalmus. We did DCT and then later underwent cataract surgery with suture tarsography. So coming to blepharitis, we know the organisms. Here the thing is, vitreous tap and the lid margin bacteria flora was identical in almost 82% of cases. It was from an old study, but still it holds relevant. So you have to clean the lid, artificial tears, then oral doxycycline in recalcitrant cases. But in some cases, still it will be very recalcitrant. In that case, you have to do an office lid massage to clean the lid properly and then go ahead with cataract. Chalazion and cataract, no literature evidence, but it is prudent to wait till complete resolution of the chalazion. The thing is, it can have acute inflammation in the postoperative period. Coming to lid malpositions, ptosis, mainly we see aponeurotic ptosis in this age group. So mild ptosis, you can go ahead, but in severe ptosis, again the discussion between the surgeon and the patient. So between cataract surgery and ptosis, at least 3 months interval. The main thing is now everything is like, highly demanding. Cataract surgery is like a refractive surgery. So when we are planning toric IOL, be careful in patients with ptosis. And another thing is roll out myasthenia gravis, because if we are doing surgery under local anesthesia, this local anesthesia, that is peribulbar block, can precipitate myasthenia gravis. So this is one of our patients which after cataract surgery presented with the total ptosis, and later we diagnosed it as ocular myasthenia. So considering phaco and ptosis, you can have ptosis aggravation after phacoemulsification. If it is done under local anesthesia, speculum can cause ptosis, topical steroids can ptosis. Bridal suture is hardly used nowadays, but still it can also induce ptosis. Coming to entropion and ectropion, here the one good thing is in the large data published in Canadian journal, no risk of post-op endophthalmitis, but there are some cases it can induce corneal aberrations, infections, etc. So again, there is a controversy. It can be done, entropion can be corrected before, along with cataract, or even after. But again, depending on case to case. So this is a one-night patient. Left eye is post-PK. So right eye we did entropion first and then cataract surgery. Coming to another entity, very common, that is thyroid eye disease. In thyroid eye disease, always, if possible, do topical phaco. Because peribulbar block can increase intraorbital pressure, can lead to complications of cataract surgery. And always surgery has to be done in inactive phase. The thing is, sometimes reactivation can occur following phacoemulsification. And the most important thing is refractory error surprise. Around plus minus 1 diopters have been reported. The thing is, there is a volume fluctuation of the orbital volume in thyroid patients. So this is again our patient came with active disease. Then later she underwent decompression radiation and followed by IOL surgery. Coming to ocular prosthesis, it is always follow one-night protocol. Each institute will have one-night protocol, and the socket should be healthy. No need to remove the prosthesis during the cataract surgery. Coming to lid tumors, so malignant lid tumors, always tumor first. So benign tumors, again you can, discussion with the surgeon and the patient, can go ahead with cataract, and later on they can come for the tumor excision if they are interested. So this is our one-eyed patient actually. You can see the black cataract with the basal cell carcinoma. So we did tumor surgery first and reconstruction, then he underwent cataract surgery. Coming to orbital tumors things are really different. Here always tumor first, because we know orbit is a Pandora's box. Radiology also can be deceptive sometimes. So we need a histopathological confirmation. So in this case, we can see she had hemangioma with a mature cataract. Right eye again schwannoma with the cataract. So we did tumor first and then cataract surgery. Again, coming to the tumors after treatment, especially after orbital radiation, they can have increased incidence of intraoperative PC plaque and postoperative CME. So this has to be mentioned and to be taken care of. And especially lacrimal gland tumors, do a punctal cautery during the cataract surgery so that the dry eye is very severe, to be taken care of. Facial palsy and lag ophthalmos, temporary suture tarsography, there is a neurotrophic element or nocturnal corneal exposure, and that can be released after 2 weeks so that patient will be comfortable and no need of any stress also. Skin diseases always do in inactive phase. We come across pemphigus cases, so they come like this with mature cataract. So always consult a dermatologist before we embark on IOL surgery. So to conclude, there are lots of conditions, and preoperative evaluation for adnexial problems very, very important. Selection of anesthesia nowadays mostly topical, but still. So careful decision making is a must to get very good result. Thank you so much.
Thank you, Marian, for that excellent talk, which covered all aspects of ocular adnexial problems. I just have a doubt. Suppose you have a patient with chalazion, and then you said it's better to tackle it before going ahead with cataract surgery. How long or how short can we wait before the cataract surgery?
At least 1 week. After INC, after 1 week, the wound heals. Then you can go ahead.